Our talk today is titled Nursing Homes, What You Need to Know. And please allow me to introduce our panelists. Before we get started with the discussion, I have Allison Peck, who is the program coordinator with the Long-Term Care Services of Ventura County Ombudsman. And I have Jody Moore, attorney with Johnson Moore in Thousand Oaks. Thank you. She is a lawyer. Okay.
Don't kick me out yet. I'm here to help.
So for both of you, our first question is, can each of you please describe the organization that you work for, what it does, who you serve, and what types of nursing home concerns are the most common in our county from your organizational perspective?
That's a mouthful.
That is.
You want to go first?
Yeah, sure. Okay. I'll lead. Hello, good afternoon. I'm Allison Peck, the program coordinator, and our program serves the residents of long-term care facilities here in Ventura County, and our goal is to ensure the highest quality of care for those residents. So we serve the smaller homes, boarding cares they're called. We serve assisted living facilities as well as skilled nursing facilities. And in Ventura County, there's about 247 licensed long-term care facilities currently. We service all of those, and our team is made up of about 37 volunteers and 8 staff members. So we visit weekly or monthly or quarterly. And let's see, what was the other part of the question?
What concerns are most common?
Most common concerns that we come across would be care concerns, we call them. So folks that need help and call for assistance, and maybe the caregivers aren't prompt at responding to their needs. Specifically in skilled nursing facilities, we refer to the call buttons, so the little button that everyone has in their room or on their bed, and getting response to those call buttons, very, very popular concern. And the other, I would say the top concern, sometimes folks find it surprising, but food. So the quality of the food, the variety of the food that meets dietary needs, anything around that food that's too cold or too hot or not enough. So all of the food concerns are very, very important to our residents, and we spend a lot of time working on that with them and advocating for those concerns.
Great. So my name is Jody Moore, and I'm an attorney at Johnson Moore. We are a law firm that's dedicated to advancing the rights of injury victims and primarily nursing home and elder abuse cases. I've been doing elder abuse law since 1997, so my whole career has been based here in Ventura County against nursing homes. The people that we serve are the victims of elder abuse and neglect. We are often contacted by the family who are trying to either advocate for better services, or something has happened and they've come to us after the fact to ask us to help investigate what happened and to see if there was any wrongdoing. We also look at whether or not there have been rights violations. So there's some really specific laws in California that protect nursing home residents and protect their rights. So we can look and see whether or not there's been a rights violation. So that's generally the population that we serve. Unfortunately, there's a little bit of a 1-2 punch. When you're in the facility, calling the ombudsman to advocate is a really good option because they have accessibility to get someone into the facility and to be working with the administration. Correct me if I'm wrong, Absolutely. Right? So they're kind of who you would call in crisis for sort of more immediate help, or not even crisis, but trying to work through an issue like it's too hot or it's too cold or the food or getting the attention that you need. People tend to call us more after the fact. They tried advocacy, it didn't work, and something bad happened. And so we would get involved to kind of unwind that and see if there was wrongdoing. The care complaints that we see, I would say we put them in 2 buckets. One is a care issue bucket, which is similar to what you're looking at, which is, are the residents' needs being identified and met? And it could be all kinds of needs: medication management, diabetic management, fall risk management, skin care to make sure they're being turned and repositioned so they don't have skin breakdown, good hygiene so they're not sitting in soiled diapers. Really, the spectrum of care that can be provided, we get care complaints along that spectrum. The other side of the coin of what we look at is really more like if it's a corporate facility, is the corporation being mismanaged? And that's more like looking at what are they spending their money on? What are their priorities for their budget so that we can see whether or not they have enough staff to actually meet the needs of the residents. So we're going to look at both sides of that coin to determine whether or not they're really in compliance with the law and providing the level of care that everybody needs.
Thank you both so much. Can you share, each of you, a little bit about what made you personally choose to serve the older adult population in this capacity?
Yes. You want me to take that one?
Yeah, go ahead.
I'll take that. I'll take that one. I actually love this. I love that I'm telling this story here today. So usually this question ends up with me talking about Grandma Ruth. And Grandma Ruth was a resident of Leisure Village. And I was born and raised here in Ventura County. So I'm sort of homegrown from Santa Paula. Went off to law school because I did local mock trial in the Ventura courthouse. One of the local appellate justices wrote my letter of recommendation, right? So I have very strong roots here. And when I first began practicing law in Ventura County, I was doing nursing home defense cases. So I was actually defending the nursing homes against suits being brought by plaintiffs. And my grandmother got sick, she had a stroke, and she ended up in a local nursing home. And I went in with my business card, right? And I introduced myself to everyone, which are some of the tips and tricks we're going to talk about today. Make sure you're known, introduce yourself to administration. I put my card over her bed and I said, take care of Grandma Ruth, okay? Right, I mustered, all 1 year of lawyer behind me. I was like a 1 year lawyer, I was a baby lawyer. And spoiler alert, they did not take care of Grandma Ruth. Yeah, she ended up with a really terrible bed sore the size of a dinner plate. We pushed the call light and nobody came. We couldn't get her pain medications. We couldn't get her diabetic medication. And she suffered and she died. And I inherited $500 and I quit my job and I went to the bank and I opened the law offices of Jody Moore in honor of Grandma Ruth. And I've been doing elder abuse litigation ever since.
Did you say $500?
$500 was my first deposit. Yep. That was it, And I was about a 2.5-year lawyer then. So opening your own practice at 2.5 years is it's a different conference we would be attending, but that's what I did. So everything I do is in honor of her, and it's been a life's work for me.
Nice. Did they learn their lessons?
I'd like to say they learned their lesson. We did bring a lawsuit. Actually, my lawyer, our family's lawyer, is now my business partner. So it's the Greg Johnson and Johnson Moore. And and we resolved the case. And I always say the best thing we get to an apology is somebody sitting across the table having to answer for what they had done. And so they had to answer very difficult questions about what happened. And that to me was accountability.
Were they punished?
Well, it depends on whether you think a lawsuit is a punishment. They had to pay money to make up for causing that suffering. Yeah.
So. Are they still in business here?
Yes. Although many facilities change hands. They change ownership and licensure. Remember I talked about that corporate bucket? And so a lot of what's happening right now is a lot of for-profit chains are coming in and taking over facilities. So the same license, the same ownership doesn't exist anymore. Yeah. Question. Am I allowed to take questions? I'm just taking questions.
Did you go through the other channels of notifying public health, and did they write them up? And there's a website that tells you all the bad things going to the website before she was placed.
Was the website up?
Yeah, so those are all great questions, and I'm happy to jump ahead. But to be honest, I don't remember if we had a positive finding from the investigation agency back then. But that is a pathway. When you have a complaint, you can file a complaint with the local Department of Public Health, and they will investigate. And my experience is a little bit hit and miss. Some investigators do a more thorough investigation than others. There's a resource management issue there. Some care issues get a little more attention than others. So like wounds get a lot of attention. Falls with fractures get a lot of attention. Something like a missed medication or an infection might not get as much attention. So it's a little bit inconsistent. But you can, as a consumer, go on the website and look at the history of a facility, see what their past complaints look like, and they have like a little scorecard with stars. So there's a 1 to 5 star rating. So we can talk a little bit about that if we want to as we move down our questions today. There is some public information to try to at least almost like a letter grade on a restaurant, to try to get a sense for whether the facility is doing pretty good or pretty average or pretty poorly.
Which website is that?
I would go to www.nursinghomecompare.gov. And that's a Medicare-based website. So if it's a Medicare certified facility, it'll have the information there.
Can you repeat that? Yeah.
www.nursinghomecompare.gov.
Dot what?
G-O-V for government, yeah, because it's a Medicare sponsored site. It's G-O-V.
How long ago did that happen?
Grandma Ruth died in 1999. Wow. Yeah. I became a lawyer in 1997. Yeah. Yes?
Is there a ratio patient per care worker that we should be aware of?
Yeah, so what I'm going to do is I'm going to park that question. I'm going to get through the rest of your introduction, and then we do have some really specific questions and staffings on there, and so I'll come back to that. Is that okay? All right.
Okay, great. My background started after college. I went into big box retail, so I was a store manager for a few different retailers for many, many years, and I loved working with large teams and managing, so I knew that was kind of my calling, but I also liked to volunteer a lot on the side for different organizations. And so as I kind of worked through my adulthood and my career, and I had my daughter, I decided to take a little break from retail, and I wanted to try working in an office. And I took a job in a dental office thinking, well, I'll help people. I like to help. They do a lot of volunteering on the side at this group that I was a part of, this dental group. And so I took this leap of faith, and I took this job as an office manager, and I didn't know anything about dentistry, but I thought I can learn. I'd like to think I'm somewhat smart. And I did learn very quickly that nobody likes to go to the dentist, including me. So I stayed there for a couple of years, and while I was there, I started to research different career opportunities, and I actually, I loved the office and the team I worked with. I just didn't love being in dentistry, but I worked with different organizations, and I volunteered a lot on the side through this dental group, so I kind of got to spread my wings that way, and that led me into deciding to pursue something with a nonprofit or something where I could really give back and enrich lives. At some point during those years when I was finding my way, I met Sylvia Taylor Stein, our executive director of the Long-Term Care Ombudsman program. And I really was touched by her and her story and her background, and she's been the executive director for about 24 years now. So we became acquaintances, and she knew my husband, and always just had a fond place in my heart for her. And then I noticed she had a position open with the Ombudsman program looking for a field services manager, which is someone that kind of oversees the volunteers and helps coordinate all that they do out in the facilities. So I applied for the position, and I was hired, which was such a blessing, and I am so grateful. This is truly the most impactful work I've ever done in my life. And at the same time, I went through the loss of my mother through cancer and my father through dementia and heart failure. So since I've been with the program, I've lived it firsthand what it's like to have a loved one in a long-term care facility, to lose a loved one in a long-term care facility, as well as care for someone at home and go through both of those situations, those deaths with hospice, being very involved. So I've really been grateful for the timing of this. And once again, I can't tell you how good it feels to work for this organization and to give back and to change lives and be an advocate each and every day. It's very challenging, very emotional, but it's worth every minute. And I really believe that we make a difference. So I'm very grateful for that. And I'm happy to be here and share anything that I can with you today.
Thank you so much. So the next question, we know that especially after COVID-19, there has been a shortage of long-term care facility workers. Can you discuss with the increase in the aging population, how it is impacting nursing home community finding staff? And can you discuss the rates of those seeking or needing to reside in a care facility, either for the short term or long term? You know, has it increased, decreased, or stayed the same?
Yeah, so this is a layered question, right? Anytime we're talking about the pandemic, we're going to talk about something that's nuanced, right? And so one way I could answer this question is to say, we had a staffing shortage before the pandemic. And we're going to have a staffing shortage after the pandemic. And so the question is, why do we have a staffing shortage? And I think there are a lot of policy answers to that. There's very low wages being paid to the frontline staff, very low wages, and very high turnover. And very high turnover is because the working conditions are not good. And the leadership is not great. Now, I'm generalizing. There are some great facilities with great leaders who are spending their money where it needs to be spent to provide good care. There are nonprofit organizations that are doing a better job because they're not answering to shareholders and distributing profits. But a significant portion of providers are using this wave to make corporate profits at an alarming rate. And so to deal with the staffing shortage, which did increase about 7 to 9%, I looked at some statistics, probably there's about a 7%, 7 to 9%, depending on the industry, nationwide, lower staff numbers than there were prior to the pandemic. Some of that is because the pandemic itself drove people out of the workforce because they had to be home taking care of their own loved ones or their children. So we didn't have infrastructure to provide secondary support for people who were making pretty close to minimum wage, right? And they had to be at home. We don't have wraparound services for transportation. We didn't have good policies in these facilities for paid sick time or quarantine time, right? So those are the kinds of things that we can look back on and trend the data for facilities that fared better during the pandemic and facilities that fared poorly. And the facilities that fared better had strong leadership and a stable workforce because they paid better than minimum wages compared to their cohort and their community. And they had good leadership, meaning that their staff members felt valued and well-trained. They weren't working double shifts all the time. Their leadership and management had their back. And so, yes, we can talk about a workforce shortage, but if I'm looking at a case from a legal liability standpoint and they're understaffed, I'm asking the questions, did you get extra funding? Did you use that funding to hire more staff? Did you contract with registry personnel? Did you increase your wages to the staff that you did have? Did you offer paid sick time so that workers, when they were sick, could stay home? So it's a really complicated question, but that's what we're looking for. We're looking for the effort by the facility to reinvest in their workforce and improve the quality of the circumstances they're working under over improving their profits. That's how we would analyze that question. I hope that's what you were looking for. Yeah.
Thank you.
So you just stated that there are several that you know of that are higher quality because profit isn't their number one thing, or it could be a not-for-profit place. Can you share some of those with the better ratings that with us? Because, you know, we're all here wanting to know.
Yeah, it's a little bit of a trick question, right? I would say that if you go on Nursing Home Compare, you're looking for the 4- and 5-star buildings, and you're looking for nonprofits, right? And so we do have a couple of nonprofits in our area. So they're gonna, now, are they perfect? No. And can you have a for-profit facility that does a good job? Yes. So it's just, it can't quite be that generalized. But you can look up and find 1-star facilities, and I would stay out of a 1-star facility. That's,
I think I can lean into that.
you want to lean into that? All right.
Just to help as a resource. So our program, we offer what we call pre-placement counseling. So if you are seeking a possible location or you're looking for a loved one and you need information, we have a very thorough list of all currently licensed facilities that's audited once a month by our program. So they're all on the up and up with licensing. And then it shows you how many rooms, how many beds they have, or the capacity of each facility, the address, who the executive director is, their contact information, and it's a good kickoff point. And then to take it to the next level, if you're able to call our office and spend a little time with us on the phone, we can dig a little deeper and help to identify what might be a good fit for you or your loved one that you're looking for. And there's a lot of factors that go into it. And a facility, we don't recommend specific facilities, but we'll definitely help steer you in a direction that sounds like would be the best fit. But to say that one facility is excellent or is always staffed or has this amazing ED, that we would never commit to, because things change on a dime. They flip all the time. Staffing changes in different departments, the executive directors, there's tons of turnover there, so it's very hard to give that endorsement. So we do not endorse, we're not on any type of commission, we just share the information, we give out the websites for how you can check any citations, any backgrounds about those facilities, but it really helps to, get some perspective. We have one staff member, her name is Vicki. If you call and ask for Vicki, she will be happy to help you. She's the most experienced with the pre-placement counseling, and it's throughout Ventura County, so we're talking about anywhere from Simi Valley all the way through Ojai. We cover those 250 almost facilities in general, but that's a great way to get some perspective and factual information and help figure out what might be a good fit, while all the while recognizing that it's your decision, but we're gonna give you some tools to help make that decision. And you can take a tour of any facility. We have a tour checklist we can provide to you to help understand and know what to look for. I see a question in the back first there.
The homes that are opening up that take in, are they licensed by you?
Not licensed by us, but they are, depending on the type of facility, they're either licensed by Community Care Licensing or by California Department of Public Health. So if it's an RCFE, a residential care facility for the elderly, which is not a medical model, that's going to be licensed by Community Care Licensing, which is the Department of Social Services. And then if it's a skilled nursing facility, so the medical model, a little more like a hospital setting, that would be licensed by California Department of Public Health. But on our list are all the currently licensed facilities. Some of them change names or change owners, or they close and open, reopen.
The ones like that are in our neighborhood, that are just homes that.
The boarding cares, that would be community care licensing. We call them CCL for short. And if you call us, we can give you, I brought one list and some program materials today. I'd be happy to share with anyone. I have my card also. I'll give that out at the end, so you can call the office anytime and we'd be happy to help.
Do they have any regulations they have to follow?
Oh, yes, very much so. Very much so, yes. I see a couple of other hands.
You're speaking strictly of nursing home facilities, you're not speaking of any memory care facilities, or you're not speaking of assisted living facilities, just strictly nursing facilities, is that correct?
Actually, good question, and we cover skilled nursing, which could include memory care or assisted livings, also known as RCFEs, that some of them do have memory care, some of them are dementia or Alzheimer's specialties, so the whole should I say gamut?
Spectrum,
Yes.
yeah.
Thank you,
Yeah.
spectrum we cover,
Yeah.
yes.
Yeah, same for us as well. I would say we tend to call it just long-term care industry because there's so many different types of providers. But it is important, and maybe a topic for another day, right, to talk about the difference between a nursing home and assisted living, because there are differences, and a lot of times what we see is someone whose care needs are really much higher than they should be for being in assisted living, and that's a really hard place to be, because the assisted livings are more home-like, and they have really good marketing teams to like bring you in the door. But if your care needs are across a certain threshold, they're non-medical, so they're really not set up to meet those medical needs. And so a nuanced analysis needs to go into that to figure out whether or not you really do need skilled nursing, like rehabbing from a fracture. You really need to be in skilled nursing for a really significant amount of therapy to get better to go back to assisted living. But some assisted living programs will say, come on in, we have therapy. And so there are a lot of questions to be asked, and having the resource like the Ombudsman help figure that out if you're trying to figure out what type of facility to go into makes a big difference.
Do you have separate lists for nursing care, memory care, or
It's one comprehensive list, but it's broken down by city and then by type of facility. So the assisted living or RCFEs are first, and then the skilled nursings are at the bottom. There's only 19 skilled nursing facilities in Ventura County, so a lot more of that list is inclusive of the boarding cares and the larger assisted living facilities. And it does state if it's dementia or memory care, if that's what you need or want to kind of cut to the chase, yeah.
Do
Yes.
you have to sign a contract once you get in there, or do you just die?
Generally, there will be an admissions agreement, but there's no, it's a 30-day lease or contract, so it's not a long-term commitment.
Do many people leave on their own?
They will transfer, we call it, so they might decide that's not quite the right home for them or setting, and then they will move by choice. So most frequently we see move due to medical needs or care needs, so kind of as the evolution of aging occurs, then they move.
Independent living, the same as assisted?
Independent living is usually truly independent, where you wouldn't have caregivers. You're more in that community, but you're living on your own in your own like unit or apartment. Assisted living kind of bounces into, it's usually enclosed buildings where they have a little more staff on hand and slightly more controlled.
And my other question, if you were 80, whatever, and you're okay.
Yeah.
Can you tour these different homes?
Yes, and
call
we
them up
we
and
encourage
say-
we encourage that very, very much so, because you want to see where you will be or where your loved one will be. And even if you don't feel ready for that now, it's always good to kind of start to study or start to look into it and see where you think that you would be most comfortable or your loved one would be most comfortable. I know when my father was living at home with my mother. When my mother passed, my father had a very hard time taking care of himself. He began to fall, and I hired some caregivers, and that wasn't even enough to keep him safe. And so then I went fast and furious and started touring facilities to find what I felt was the right fit for him. And it took numerous till I really felt confident and I did my homework. So the more, the better up front, but we're here to help as well. I think we can help you, lean into that and come to an educated decision. One other thing I want to point out is that skilled nursing facilities, the medical model we've been talking about, the 19 in Ventura County, those are generally supported by insurance or insurance, they accept insurance. Assisted living, independent living, boarding cares do not. They are all private pay. So they're owned, they're privately owned. So the funds for those come out of pocket from the resident or from their loved ones. So that's a big consideration, something to keep in mind. Maybe another topic for another discussion, but just putting it out there because that's a question that we get numerous times throughout our days in our office.
So can I expand on that? Because I think it's really important. The skilled nursing facilities, even within a skilled nursing facility, there's two kinds of care. There's the skilled care, which is I need therapy, I need IV management. It's typically PT, physical therapy, occupational therapy, speech, or some sort of heightened nursing skill. But many times what happens is, let's say there's a surgery and then this period of rehabilitation. That is covered by insurance. But after a certain number of days, and if you ask me how many, I'll tell you it depends, okay? But after a certain number of days, a decision is made by not the family or the resident, but people associated with the insurance. You don't qualify anymore. And then you either have to leave, you have to transfer to somewhere else, or you can convert to what's called a custodial patient. So you don't need a skilled need, physical therapy, occupational therapy, or a skilled nurse doing an IV or something like that. But you can't really go home, right? You're not stable, maybe you're at risk for falling, maybe you have dementia, right? So you can convert to custodial. And at that point, you're either going to go back to private pay if you have any means, or you have to qualify for Medi-Cal. And so that's its own burden, its own financial issue. Do you have so little assets that you qualify for Medi-Cal? So that's another thing that gets very confused is, well, but I'm in the nursing home and I can't go home. Why are you kicking me off of Medicare? But Medicare only pays, it's traditionally around 20 days as a general rule of thumb. If I'm getting a case and I'm like, oh, this person's rehabilitating from surgery, I go and look what happened on the 20th day. Because I know Medicare dollars change on the 20th day. And it's very common to get a notice, you no longer qualify for Medicare on the 20th day. Doesn't happen every time, but it's a clue, it's a pattern that I'm looking for. So that's something that if you can think about that before you ever leave the hospital, right? How long am I going to stay here? Can I convert to Medi-Cal? And if I can't, do I need to get a Medi-Cal planning attorney involved? There might be some more complex questions. Do I need to trigger my long-term care insurance? Because after this period of time, I need continued care. So just keep that in mind that even though it's the same building, not all beds are the same. Some beds are Medicare beds and some beds are not. And who pays for them depends on where your what your skilled needs are. And who decides that is not the patient. It's somebody else. It's the doctor, it's the managed care company, it's the HMO, something like that.
Great, thank you. So the next question,
Let me ask Allison a question.
Yes.
Clarify, you said 19 skilled nursing facilities. Of those 19, how many are not-for-profit?
That's a good question. 2 or 3?
Two, I want to say two.
I think you're right at 2. And the reason I clarify that is so that everybody understands, if I only want to go to a not-for-profit facility in Ventura County, your choice is 2 facilities. They're both relatively small in relationship to 99 beds and above. And so the options, you know, if you think I'm only going to want to go in one direction, that's just not realistic if you want to stay in the county.
Yes, good point. Thank you. I'm glad I got that slight guess correct.
Yeah.
Thank you. So the next question, what do you think the future trends show for these issues that you all just discussed?
Well, I'll start. I'm sure you can lean in more. I'd like to think optimistically. We're turning the corner on COVID. The awareness is very at the forefront of our state legislation and state office. With the ombudsman program, we have a state ombudsman. Her name is Blanca Castro, and she is in charge of pushing legislature and getting bills passed and helping to be the voice. So she's got a strong voice and a strong hold on what we have learned from the past. The issues that we've talked about so far today with staffing and care concerns and how facilities are led. And so she's kind of up here on this level working on it through the state and through government. And then here, at ground level, we're working on advocating with the staff and working with them to be sure that the leaders know what the staffing gauges are, that they know what the expectations are, that they are educated on residents' rights, that they are working towards a stable and safe environment, and it's not about being threatened to be a complaint being filed. It's doing the right work at the ground level each and every day and treating their staff well and paying them well and looking at benefits for them. So there's work to be done, absolutely, but looking at where we've been and where we're headed, things should be headed in a more positive direction from what we see in the facilities. There does need to be a dramatic emphasis and we need to stay the course on staffing. That's the one big one. We have a great partnership through our agency with Community Care Licensing and California Department of Public Health. So we work closely with them to help be their eyes and ears as well and identify, opportunities in what we consider to be problem facilities, helping to recognize the facilities that are well run, to give them, the kudos that they deserve and use what they're doing as examples of how to improve in other facilities. We're also working on quite a bit of education for staff within the facilities. So we will go out into the facilities and do what we call in-services to help train the staff on residents' rights, on confidentiality, on dignity and respect. So those staff members understand what it's like to live in a long-term care facility, what it's like to be treated respectfully, what that needs to look like and what the laws are around that. So there's more of that going on than ever before. We've learned a lot from COVID and isolation and being held out of facilities and not being able to visit facilities and folks unfortunately passing away from that isolation. But now going forward, we're stronger for it and better for it, and there's more legislation around it and more work being done to improve that. I see one question over here. Yes.
I have 2 questions. Once I've been around several people who, when they were ready to be discharged from the hospital, the only options for them were certain nursing care facilities. And some of them weren't so fabulous. So what does one do at that point? The other part is, if you are in a nursing care facility and you have used your 20 days, how often are appeals recognized?
Want me to take that one? Okay. Are you able to hear us okay? Yeah. Okay.
Much better.
Oh, is that better? All right. Well, I've never shied away from a microphone. So I'll repeat the question. I think it had two parts. One was, what do you do when you're about to be discharged or your loved one is about to be discharged from a hospital and you only get so many choices and they're maybe less than stellar. They're not in your top 10 list, which is kind of a related issue over here that came up, I think, if you can't get into a nonprofit. And then the second question, I already forgot the second question. Well, I'll come back to let me.
It's when you've been given the 20-day notice, it arrives on the 20th day.
Yeah.
How often
Appeals.
are appeals honored or?
Yeah, so she's asking if you get a notice to leave the facility around that 20th day. One, you do have a right to appeal, so it's how often are those granted? So I'll give you my perspective. On the discharge list, that is a common issue. You know, what often gets presented is the doctor has ordered your discharge, and at 2 o'clock today, you will be going to such and such. Please sign here. Okay, and the family may or may not even know, right? And so a series of frantic phone calls happen, and then the family member, if they're lucky enough to look it up or to call the ombudsman or call someone like me, and we're like, no, that's not a great place for them, right? We're like, stop. May or may not be able to intervene. If you have the luxury of working with or establishing a relationship with a social worker at the hospital, do that immediately so that this discharge issue doesn't come as a surprise, right? If someone goes in with a fall fracture and they're going to have surgery, they're going to be there 2 or 3 days. I want to talk to the social worker right away about what a discharge would look like for my mom or dad or husband, okay? And say, I have preferences, where do you think this person will go, and so forth. I don't believe, my bias is coming out, when they say the only facility in the county of Ventura that can take your mom is such and such, okay? There is a resident's right to participate in a comprehensive discharge plan. You have the right to call the facilities yourself and say, hey, do you have any beds open? Now, those answers are not always accurate because the facility is looking for a specific type of person, and I don't mean age and rank and serial number, I mean payer source. Okay, so they may say something like, oh yeah, we have plenty of beds open to the family, and then they get the transfer packet and they realize it's a really high needs demented patient who's aggressive and on 27 medications, and they're like, no thank you, right? Like, we don't want that one. And they go, we don't have any beds available, right? And that's really hard to test in the moment. So my best advice on that is understand the discharge plan as early and as often as you can. Make yourself known to the social worker, whoever's going to be part of the discharge. Know that you have the right to choose a facility and say, I'm going to need more choices. I'm going to need time to research and investigate. Mom's not leaving today at 2. You have the right to say that. And they'll bully you. They'll say, no, they got to go. The doctor ordered it. Okay, great. I'd like to talk to the doctor, right? I'd like to tell the doctor, I don't have anywhere for mom to go yet, and so I want my mom to stay another day. So you can push back on that. The other sort of coaching, if you will, that I've done is to say, I think that's an unsafe discharge. Oh, shit, it's an unsafe discharge. Sorry, I didn't ask if I could curse. You gave me a microphone. It's an unsafe discharge. You can't have an unsafe discharge, right? So what would make it unsafe? Well, I don't know if they can meet mom's needs because I haven't investigated. I haven't asked these questions. I don't know if they can manage her diabetes or her dementia or her physical therapy. I need time to look into that. So you can do all of that. What if they're in the facility? So second part of the question is, what if they're in the facility and now you get a notice that Medicare is no longer covering their services? Same thing. Well, I don't have anywhere for mom to go, right? Because you'll get that notice on a dime too. Your mother needs to be out by 2 o'clock, or I need a check for $5,200 for the next 20 days, right? You're like, oh, what? I don't have $5,200. I don't want to give it to you if I do, because this place maybe is not the greatest place for my mom. So do the same thing. Establish the relationship with the social worker. They're the ones who are coordinating the discharge. Let them know who you are on day 1. There's actually a regulation that says discharge planning starts on day 1. Okay, I want to know what the plan is. I want advance notice. I need to get medical equipment set up at home. I need caregivers set up at home. I need to find a boarding care if that's where mom's going. Make sure they know that you're active and involved and advocating and present. You can file an appeal, and it has to be on the notice of Medicare non-coverage. It'll say to file an appeal, call these people. You can do that, and it will buy you more time. So that's my number one reason why I tell people to do that, is it will buy you time, typically 48, 72 hours. I have about a 8% success rate that anyone's even ever changed their mind, including we did that with my own grandmother, right? So the appeals panel tends to just defer to whatever decision was made at the facility level. That's just the reality of what happens. But it will buy you the 2 or 3 days so that you can put plans in place or come up with the money or decide how it is that you're going to adapt.
Do you have to pay them if the appeal file fails? Do you have to pay for the extra days till it comes through?
That's a good question. I believe you do not, but there's a nuance to that, which is also like if you're converting to Medi-Cal, if you are in fact going to convert to Medi-Cal, Medi-Cal will back pay those days. So, but I don't know that for sure. That is a question that I would have to look up to know the answer for sure. Question here.
You better make sure that you familiarize yourself with other than just one social worker.
Typically,
when you call
yeah.
and want to speak to them, oh, they're on vacation or they're out sick. So
Yeah.
you have to get several people who you communicate with. Otherwise, that's exactly what they'll tell you.
Yeah, and there might be multiple social workers in the hospital setting, but most buildings only have one social worker. And so then I would say, who is doing the social worker's job in that person's absence, right? Or I would like to speak to the director of nursing, or I need to speak to the administrator. So again, you can go up the chain of command. And I always like to talk to the doctor as well, because the doctors are typically oblivious that any of this is happening. They've signed some discharge order that somebody sent them. They got a phone call, hey, Mrs. Jones is ready to go home. Okay, sign the order. And that's all they know. And so if you can get the doctor on the phone and be like, did you know that they're kicking mom out at 2 o'clock and I don't have a bed and I don't have a wheelchair and I don't have, like, what can you do? And they can call the facility and say, let's give the family, 48 hours to make their arrangements or something like that. Yes, question.
There are 3 to 4 social workers in every hospital. I work as a discharge planner in 3 hospitals. There are at least 3 to 4 social workers. There's a whole department unit in every acute care hospital.
Right, and I think I said that in the acute care setting, you're going to have multiple social workers, but in the facility themselves, the skilled nursing facilities, they typically only hire 1. In fact, I've had lots of cases where the position itself was open. They didn't have any because they couldn't fill the job. But I don't think I've ever seen a facility that had multiple social workers. They have 1, they work 9 to 5, Monday through Friday. It's very common to have a discharge happen Friday afternoon at 4 o'clock, right? And then, oh, oops, I can't put you in touch with the social worker. She doesn't work on the weekends, right? So some of that timing is difficult. It's very, very difficult on the families to deal with that. So use the Levanta appeal that'll be on the Medicare notice of non-coverage, especially if it's a Friday. Use the appeal so you can buy yourself a little bit of time. Use the doctor, especially if you're in like an HMO or you have a long-standing relationship with that doctor, and say, I need help. Mom or dad or my husband or my wife is not ready to come home. I'm monopolizing the microphone.
You're
so
doing
they gave
great.
it to me.
You are doing great.
I see you're nodding, so I'm on track.
I completely agree. These are calls that we take daily as well. And I would just say, don't leave. That's the first thing we say, don't leave. Don't let them kick you out or your loved one out. We have a postcard we can send to you easily that tells you about your rights and discharge and the safe discharge. It summarizes it quite nicely. A friend of mine called me a week ago. Her mother's coming out of skilled. They wanted to push her out. She feels she needed more, the daughter felt she needed more PT, physical therapy. So she called me just, in a panic. I don't have another place lined up. I'm not sure where we're gonna go. We can afford to move her somewhere, but I don't know where to move her. I said, just sit tight. Here's the ED's number, here's social services name. Give them a call, tell them you do not have a safe discharge in place, and you would like to know what that is and what that entails, and that you also feel that the PT has been insufficient or she's not ready to go. So talk to the doctor, communicate, do not leave. So within 2 days, she gave me a call back, or I think it was a text message, and said, she's still there. We're working on placing her at a location in Santa Barbara. Thank you so much. That bought us the time that we needed to make that adjustment, and she was in such a panic. So it does happen. Really good questions, and just once again, don't leave, and get in touch with the doctor, the social services director. And if there's not a social services director on duty, just to Jody's point, just ask who is in charge or who's filling in. If you can't get anywhere with that, give our office a call and we will help you muddle through that.
I see a question in my
Yeah, lots of questions.
Don't they have to give you, I'm listening to all this, I've gone through a little bit of this myself, but not quite to the extent you're going. Don't they have to give you like a day or two to prepare for this, or they can just say, get out?
Yeah, the question is, don't they have to give you a day or two? Not really. I mean, let me tell you what the law says. The law says that you have to have a comprehensive and safe discharge, and it has to be a multidisciplinary process, and that the resident and the family should participate, right? That's what the law says. Is that what happens, right? No, what happens is, here's your piece of paper. You need to leave by 2 o'clock today, or you need to give me a check for $5,200. That's what really happens. And so what we're talking about is how to back that up to, that's an unsafe discharge. I don't have all of the plans in place. And it is the responsibility, and it's written into the law, right? It is the responsibility of the facility to ensure the discharge is safe. And what happens is families panic because they think it's the family's responsibility. Like, who do I call? What home health agency do I need? What medical equipment do I need? How do I get their medications? They've been here. I don't have any medications at home. I don't have a caregiver to spend the night, right? And so those are the things that need to be said back to the facility so the facility understands that's what makes this unsafe, because ultimately it is the facility's responsibility to ensure someone can be discharged safely and their needs can be met at home, right? And so there's just a disconnect between the reality, right, what we see happening and what should happen if they're following all the rules. I wanted to answer your question though. I parked your question on staffing, and because we're still on the trends question, even though I'm looking at the time, we talked a little bit about staffing trends. So I'm going to echo that COVID has shown a light on bad things that are happening, right, in our nursing homes, and that we need to be paying attention because this population deserves better. I definitely believe that. I'm a little less optimistic about an about face, because again, I'm looking at the corporate. I'm looking at how much money is being made and how the money is being funneled into private citizens, right, into wealth. And so the silver linings or the highlights for me are our staffing rules did change in California in 2019, I think, right before the pandemic. We do have a minimum staffing ratio for nursing homes, and you have to have 3.5 nursing hours per patient per day in a nursing home, and of the 3.5 hours, 2.4 hours have to be direct care CNAs. So that may or may not sound like a lot, but it used to be 3.2. So the number's definitely gone up, and that shows that California is paying attention from a legislative standpoint, that we need to do better. All of the studies say for baseline minimum care, you should be closer to 4.1. So I still think 3.5 is never going to be enough. But we are seeing the law catching up and trying to make up for that and trying to improve the quality of care. I just hired a new attorney in my firm. She came here from South Carolina. The number there was like 2.2. So California definitely is doing better than what we're seeing nationally. So that is a bright spot, and it's a trend in the right direction to require more staffing. The other thing is that our residents' rights laws recently changed as well, and our limitations on damages have gone up. So the legislature is paying attention. The California specific legislature is paying attention to this population and trying to do right by them by affording more protective laws. There's just a really strong lobby, for-profit lobby, right, on the other side that makes changing the law really difficult. So I would say we're taking baby steps, but they're going in the right direction. So that does make me feel optimistic that we're doing a better job keeping an eye on and improving the quality of care.
Another question in the back?
Many discharges occur on Friday afternoon about 3, 4 o'clock, and it's done by utilization review and the IPOA, whichever you're affiliated with your HMO, unfortunately. Okay, I just want to point something else out that's really important. We're building a lot more assisted living facilities than nursing homes. When was the last time you saw a nursing home being built in Ventura County?
Yeah, good point. There are a lot more assisted livings than skilleds, and they continue to grow. More boarding cares as well.
Because they make more money?
Yes, privately owned, so they can charge whatever they want for profit. One more question in the back?
Yes, describe the requirements for skilled nursing to post their staffing hours in the building. The attorney mentioned the requirements, and that's good, but there's been a long-term requirement that the actual hours are posted every day in the facility.
Right, so when you walk into the front door of any skilled nursing facility, you should be able to see on a poster board near the entrance or near the director's offices what their staffing level is for that day. So they'll say, we have a total number, the census, the total number of patients in the building, we're providing this many hours of nursing care, and they'll break it down by RN, LVN, and CNA, and then they just do math, right? For the total number of hours in a 24-hour period, divided by the total number of residents, that's how you get that 3.2, 3.5, 3.7. And they are required to post that daily. One of the problems we have is that a lot of times we would call that posting aspirational. Like, we think we'll have this many nurses working today, but it doesn't reflect the call-offs or change to the schedule because someone actually is going on vacation, things like that. So, or they're homesick, right? That's a call-off, right? And so when we look at that, we get those, and to do our sort of retrospective analysis, we actually compare it to the time cards, right? And we go, well, they said they had, 8 RNs and 6 LVNs and 42 CNAs, but they actually only had 1 RN, which is another issue, is they're very understaffed in RNs. To make this number, right? Because then 8 hours is 8 hours is 8 hours. So I can have an 8-hour CNA making $18 an hour, or I can have 8 hours of an RN making $47 an hour, and it's the same 8 hours going into my computation, right? So I'm incentivized to use the lower dollar, right, pay scale to make up those numbers. Now, I'm not saying that's bad. We need CNAs. We always need CNAs at the bedside. They are the actual people delivering the care. They are doing the diaper changes and the feeding, and they are monitoring something's not right with Mrs. Jones. So I'm not taking anything away from having a robust CNA population, but I do have a problem when you have 1 RN in the building for 122 people, right? Only an RN can assess under California law. So if you only have 1 RN, and this person over here's skin is breaking down, and this person is falling, and this person has an infection, that nurse can't handle all that. Oh, and by the way, there's 3 new admissions, which only the RN can do, right? They can't handle all of that. So we need to be advocating for higher registered nursing and make sure that there's good leadership. That's one of our policy issues, is making sure we have really strong leadership. And that comes in the form of registered nursings leading the nursing teams in the facilities so that people don't fall through the cracks, which that's sort of my lay definition of neglect, is they're falling through the cracks. But the problem is the cracks, we all know they're there. And we're not doing what we need to do to make sure the cracks are being sealed, which is more nursing, less profit.
Sure.
Any other questions?
Would both of you address the issue of reimbursement in the long-term care industry, its role in the concerns that you've expressed? It's great to pay people more. It's great to work to educate so you have a larger workforce, and it's great to do those things and increase the hours per patient day. And I wholeheartedly support that. But if you look at the reimbursement issues with Medicare and Medi-Cal, the skilled nursing facilities specifically struggle mightily to make it an operational going concern.
That's a very good point, and it's a kind of a heated topic, one that the Ombudsman program, we don't go there. Our role is to be frank, we're here to advocate for the residents to get them the best care possible, and it's up to the facility to establish what that looks like for reimbursement or billing, or going back to Medi-Cal and fighting for that. So I don't have much of a voice with that, but we do discuss within our program private pay, what that can look like, the ranges that we hear and see out there, what you get in return for that, what that can look like. So not to skirt the question, but it's just not something that's in my wheelhouse.
It's in mine. So it's a yes and no. There's a very strong part of me disagrees with that, and here's why. The last nursing home chain that I went to trial against, it was a single owner operator. It was a chain of 200 facilities across the nation, and he's on the Forbes list as a billionaire, and he's made every single dollar from tax dollars from Medicare, right? So we have forensic accountants that go through and look at their books in order to try to answer this question, because jurors want to know. The jurors want to know, well, was there more money to pay for more staff? That's the bottom line. And we have to show that. We have to be like, yes, they could have hired more staff. Here's where they could have hired it, as opposed to, executive compensation. One of the largest providers here in California, flies around on his private jet, and that's a business write-off, right? So there is a lot of excess spending as well that we can look at through the auditing process that is not just trying to make ends meet. On the Medi-Cal side, you're absolutely right. The Medi-Cal reimbursement is really dismal, but that has been adjusted over time as well. So what has happened, and I've been in this business for over 25 years, but they change the reimbursement all the time. So it's a moving target to figure it out. It used to be PDPM, right? And then it was based on RUG scores, right? There's all these acronyms, and it's like you have to be a healthcare finance expert to understand it. It used to be that the higher your care needs, the higher the reimbursement. Well, so now, if I'm taking the sickest patients that need more staff, I'm getting paid more. So now I have more money and resources from the government to hire more staff. And that's why I'm saying there's a part of me that really strongly disagrees with that. If you're going to take the sickest patients and you're going to get $900 a day instead of $122 a day, then I expect to see that differential trending your staffing line up. And we don't see the trending of the staffing lines going up. What happens with the staffing lines is they match the minimum. They were 3.2 for decades, and now they're 3.5, maybe 3.6 or 7 to build in a tiny little cushion for the call-offs and the vacations, right? Even the Medi-Cal reimbursement, they changed throughout the state. The cost of expense of running the facility allowed them to increase their reimbursement. So someone in a high rent district who's paying way more on their lease is going to get a higher reimbursement than somebody who's maybe in Bakersfield or Fresno who's not going to pay Camarillo rates. So there is a lot of adjustment that's being made to make sure the reimbursement is matching the need. We're just not seeing the reimbursement being funneled back into the care.
Thank you so much. Well, thank you everybody for your time today, and thank you to our speakers.